Hello, in this video we are going to discuss the pathology that is related to the pulmonary system, and our first topic is sarcoidosis. One main thing which you need to remember about sarcoidosis is it forms non-caseating granulomas, whereas TB form the caseating granuloma. So whenever there is a mentioning of the word non-caseating, then you are going to tick sarcoidosis. Non-caseating granuloma is present in sarcoidosis. All the MCQs that is related to the point 96 are related to the sarcoidosis, and everything mentioned non-caseating granuloma. Moreover, the most common feature of sarcoidosis in female is erythema nodosum. And if there is a question granuloma with asteroid bodies, that is also seen in sarcoidosis. However, if both options are given, that the sarcoidosis is diagnosed macroscopically by, then you are going to take non-caseating granuloma, not the granuloma with asteroid bodies. And the type of cells which are involved in sarcoidosis are T lymphocytes. This is important. These are 4 or 5 points that you need to remember for sarcoidosis. Moreover, the hilar lymphadenopathy, multi-system involvement, hypercalcemia with non-caseating granuloma are the characteristics of the sarcoidosis. Schwann bodies are also found in sarcoidosis. Now, point number 97, which is also related to granuloma. The caseating granuloma is found in TB, and non-caseating granuloma is found in sarcoidosis. There are two more granulomas which are important. The one that is with the yellow pigment or with an abscess, that is actinomycosis. So whenever there is a granuloma with the pigment or with the abscess, then you are going to say actinomycosis. If there says a granuloma with separation, then that is going to be nocardia fungus. And another important thing that you need to remember, that there is a Ghon complex. The primary Ghon complex is found in the TB, that is present in the primary TB, and is the granuloma with associated lymphatics, right? So let's discuss the MCQs. Patient had tooth extraction. Microscopic feature of actinomycosis infection is granuloma with abscess, not the yellow pigment. We are going to take the granuloma with abscess. This is important. The next thing is a diabetic patient after tooth extraction develop an abscess. And histology, the characteristic feature of actinomycosis is granuloma with abscess. We are going to take granuloma with abscess. Scenario of diabetic patient draining abscess from the jaw. What is the finding on macroscopy? The answer is going to be granuloma with abscess. Most common cause of granuloma with separation is nocardia fungus. Now, few more MCQs. Epithelioid cells in TB granuloma are derived from macrophages. Which of the following is the most characteristic of granuloma? That is epithelioid cell. An epithelioid cell in TB granuloma are derived from macrophages. We have already discussed that the primary TB granuloma complex or the Ghon complex is a granuloma with surrounding or associated lymphatics. A patient with cervical lymphadenopathy, chest X-ray show bilateral hilar lymphadenopathy. The biopsy show caseating epithelioid granulomatous pattern. So that is caseating, so that is going to be TB. How sarcoidosis is differentiated from TB, that is also the granulomas, that is a non-caseating and caseating granuloma, but if that is not an option, then you are going to take symmetrical bilateral hilar lymphadenopathy. A patient has cough fever for last 3 months. He also has cervical lymphadenopathy and a non-healing ulcer on tongue. Pathology show granuloma with caseous necrosis, and that is going to be diagnosis is going to be TB. Then there is another long scenario in which it's mentioned it has non-caseating granuloma. The condition is most likely to abnormality in the function of T lymphocyte, that is sarcoidosis. An alcoholic female present with cough and hemoptysis, that is a typical picture of the TB, and it also mentioned that it has a alveolar washout of few epithelioid cells. What a probable diagnosis? The diagnosis is going to be TB. Most diagnostic test for TB is PCR. If there are more options, for instance AFP and cases, then you are going to take PCR. However, the definitive diagnosis is sputum AFP. For example, there are MCQs. Scenario of TB is given in cases necrosis seen. The diagnostic test is going to be PCR. Test for definitive diagnosis of TB is demonstration of AFP. A 20-year-old female presented with cervical lymphadenopathy. Histological examination of the lymph node revealed granulomata. Definitive diagnosis of TB is a demonstration of AFP tissue specimen. An old patient with weight loss, patches in lungs, hemoptysis, epithelioid cell. The next investigation should be AFP. Inguinal lymphadenopathy patient was having TB. Definitive investigation is going to be AFP. A boy came from Afghanistan with discharging sinus and a lateral neck with night sweats and fever. Culture showed no growth. Which next confirmatory test should be done? That is also biopsy. That is going to be biopsy, right? If biopsy is not given, then you're going to say Zerrin staining. Alright, AFB is the non-resistant, non-capsulated bacteria due to cell wall glycoprotein. There is a question that asks the histological feature of TB granuloma, then you are going to take epithelioid cell, right? The diagnostic of granuloma or TB granuloma is epithelioid cell. If asked the macroscopic feature to diagnose TB granuloma, then the answer is going to be caseous necrosis. A 35-year-old female presented with infertility, uterine tubes were blocked, and histology of endometrium revealed epithelioid and giant cell. The likely cause is going to be TB. Now there are a few more MCQs that you need to know. In which of the following there is lymphocytosis, that is TB. There are a few more MCQs that you need to know that are related to leprosy. Nasal lesion, if there is a mention of the nasal lesion or the lesion near the orbit of the eye, or that is the TB lepri or the leprosy. Initial test to detect microorganism of leprosy is a nasal scraping test. So this was about the tuberculosis. Let's discuss a few more points related to tuberculosis. So if there is a mentioning of fever, cough, and the epithelial cell and diffuse nodular opacity on the chest X-ray, the diagnosis is tuberculosis. And if there is also mentioned the enlarged cervical lymph nodes and the chest show hilar lymphadenopathy, the diagnosis is going to be TB. And if there is fever, night sweat, hematuria, urine RE show this, ultrasound is unremarkable, the cause is renal TB. Antibodies in TB are bound to cell. The airborne infectious disease is TB. A patient took ADT drugs, now presented with elevated ESR. This is due to the superimposed acute bacterial infection. A 50-year-old smoker complained of dry cough, fever, and malaise. His chest is clear. On X-ray, there is a left apical shadow. Mental test is positive and ESR is 90 mm per hour. The diagnosis is TB. Finding of pulmonary TB is primary focus in parenchyma with the involvement of the regional lymph nodes. The Gone complex is a feature of primary TB. Most likely cause of negative Montauk's test in patient with TB would be immunosuppressive therapy. Regarding pulmonary TB, what is true is that it involves the posterior segment of the upper lobe lung. A man working in a mine come with history of low-grade fever, cough, X-ray show left apical consolidation. The Montauk's test is positive. The diagnosis is going to be TB. Now let's talk about the anti-TB drugs. So there are 5 most important drugs that are first line: isoniazid, rifampicin, ethambutol, and pyrazinamide, and streptomycin. So they are important. The side effects of these drugs are more important. For example, the isoniazid are going to cause peripheral neuropathy and hepatitis. And for prevention of peripheral neuropathy, the pyridoxine, that is B6, is added with the isoniazids in their anti-TB regime. Rifampicin give orange red color secretions and does not need any treatment. Ethambutol cause optic neuritis, that is color blindness. So what you are going to do, you are going to reduce the dose or stop dose need adjusting in renal impairment too. So, all right. Then pyrazinamide is the causing hepatitis, photosensitization, hyperuricemia, and gout. Streptomycin causes the 8th nerve damage. Use only if the patient has multi-drug resistant, contraindicated in pregnancy. Streptomycin is not given in pregnancy and it is only used when the patient has multi-drug resistance. Now let's talk about the MCQs. Which of the following is not safe in pregnancy? That is streptomycin. Which drug is eliminated from the body without significant metabolism? That is streptomycin. About ethambutol, the most important thing is that it causes the optic neuritis, that is the color blindness. The patient is taking multiple drugs to treat his TB and is unable to differentiate between red and green light. Drug responsible is ethambutol. Optic neuritis, red green color is shown. TB patient taking anti-TB is due to ethambutol. A patient on EDT developed blurring of vision, that is due to ethambutol. Which anti-TB drug is bacteriostatic? So bacteriostatic is also ethambutol. About isoniazid, isoniazid induces hepatic injury, and hepatic injury is going to be increased by N-acetylcysteine deficiency. The peripheral neuropathy in TB is prevented by giving vitamin B6. Patient at ATT has pin and needle sensation. What should be given? Vitamin B6. A patient ADD drug present with pin and needle sensation, what drug should be stopped? So isoniazid. Pins and needle sensation is basically telling us about the peripheral neuropathy, and vitamin B6 is given along with the isoniazid in order to prevent peripheral neuropathy. About rifampicin, red color urine drug is responsible. Rifampicin, a female on anti-TB drug using OCPs but still conceived. Which drug is responsible? So that is rifampicin. A patient undergoing TB treatment complained of orange-pink discoloration of urine. Which of the following drug is responsible for it? That is rifampicin. Patient on anti-TB drug developed right big toe swelling. This is due to which of the following drug? That is pyrazinamide because it causes gout. Patient on ADT developed hyperuricemia. That is also pyrazinamide. Anti-TB drug can cause hyperuricemia. That is pyrazinamide. There are more MCQs. That is why are anti-TB drugs given in combination? So that is to decrease the resistance emergence. Which of the anti-TB drug is bacteriostatic? As we already discussed, that is ethambutol. That is a pure bacteriostatic drug. And the pure bactericidal drug is pyrazinamide and rifampicin. There is a drug that has both properties, that is bacteriostatic as well as bactericidal, and that is the isoniazid. Isoniazid is bactericidal for bacilli in rapidly dividing phase and is bacteriostatic for bacilli in stationary phase. So bacteriostatic is ethambutol and bactericidal is pyrazinamide and rifampicin, and isoniazid is both. So let's talk about roughly 0.103 that is related to the carcinomas that is related to pulmonary system. So if there is mesothelioma is being asked in the MCQs, and you're going to take asbestos because the causative agent of the malignant mesothelioma is asbestos, and asbestos also causes the bronchogenic carcinoma. And then if there is a bronchogenic carcinoma, then you're going to take smoking. Smoking is related to the bronchogenic carcinoma. The occupational carcinoma or the construction factory carcinoma is related to asbestosis, and coal mining or the sand blasters that are related to the silicosis. Now let's talk more about these diseases. The asbestosis is associated with shipbuilding, roofing, and plumbing. So it is from the roof. That is was common in insulation before time, but affect the base, that is the lower lobes, and that is associated with increased incidence lung cancer. It causes more bronchogenic carcinoma than the mesotheliomas. Whereas the silicosis is and coal, that is the coal workers pneumoconiosis, they affect the upper lobes. Coal worker pneumoconiosis is self-explanatory. It is caused by the inhalation of the coal dust, and which contain both carbon and silica, and also known as a black lung disease. Whereas the silicosis also affect the upper lung, is associated with glass manufacturers and stone cutters. Stone cutters, sandblasters, or coal mining, and they are associated with the silicosis. It is thought that silica may disrupt phagolysosome and impair macrophages, and it also increases susceptibility to TB. The actual classification of hilar lymph node is seen in silicosis. So the coal workers and the silicosis are from the base, that is the earth, but affect the roof, that is the upper lobes. And asbestosis is from the roof, but affect the base, that is the lower lobe. Bailosis and anthracosis are two other diseases. Anthracosis, like the coal workers pneumoconiosis, is also caused by the inhalation of the carbon dust. It is endemic in urban areas and it causes no harm. Bailosis also affect the upper lobe and associated with exposure of beryllium in aerospace and manufacturing industries. Granulomatous on histology and therefore occasionally responsive to steroids. So it is granulomatous on histology and therefore occasionally responsive to steroids. Let's discuss a few more diseases that are discussed in the Duffy point 105. There is farmer lungs. Farmer lungs is caused by the hay, moldy hay or grain dust. And the agents involved are the Aspergillus fumigatus and the Micropolyspora fini or Polyspora erectivirgula. These are the agents of important Aspergillus fumigatus, that is important agent of the farmer lungs, that is caused by the hay or grain dust. Whereas bird fancier lung is caused by the avian excreta, proteins, and feathers, and avian serum proteins are the causative agent. Biocinosis is basically caused by the textile industry. The agent is the cotton dust. And in humidifier fever is the contamination of the air conditioning, and that is caused by the thermophilic actinomycetes. Malt workers Aspergillus clavitus. So in the investigation for these diseases there is going to be no eosinophilia except allergic bronchopulmonary aspergillosis, that is going to cause the hypersensitive response to aspergillus growing in lung mucus, and it is associated with asthma and cystic fibrosis, and it is going to cause bronchiectasis and eosinophilia. The blood investigation is going to reveal no eosinophilia in all these diseases except in one case, that is the allergic bronchopulmonary aspergillosis that is associated with eosinophilia along with asthma and cystic fibrosis, and it may cause bronchiectasis as well. Let's talk about pneumothorax, that is Duffy point 106. So there is a primary spontaneous pneumothorax, secondary spontaneous pneumothorax, traumatic pneumothorax, and the tension pneumothorax. Primary spontaneous pneumothorax is due to rupture of the apical bulbs or cyst and occur most frequently in tall, thin, young males. And the secondary spontaneous pneumothorax is due to a diseased lung, for example, bolon emphysema, infection, mechanical ventilation with use of high pressures, that is a barotrauma. So that is a primary spontaneous pneumothorax, and then the secondary spontaneous pneumothorax. And then there is a traumatic pneumothorax that is caused by the blunt or penetrating trauma. A blunt trauma could be a rib fracture, or a penetrating trauma could be a gunshot trauma. The tension pneumothorax can be any of the above, and air enters the pleural space, but it cannot exit. And there is going to be increased trapped air, that is a tension pneumothorax. Trachea deviate away from the affected lungs. So in tension pneumothorax, trachea is going to deviate away from the affected lungs, and there is going to be increased trapped air, that is a tension pneumothorax. Air enters the pleural space, but it cannot exit, and the reason can be any of the above. In traumatic pneumothorax, that is caused by the blunt or penetrating injury, and the secondary spontaneous is due to the diseased lung, and the primary spontaneous pneumothorax is rupture of the apical bulbs or cyst. In this video, we are going to talk about the embolism, the thromboembolism, all the theory that is related for your Fcps Part 1 exam. So let's get started. So there is five type of embolism that are discussed. The one is a pulmonary embolism. The pulmonary embolism is one of the most important cause of sudden death, usually occurring in immobilized post-operative patient and those with congested heart failure patient. Immobilization is going to lead to venous thrombosis in the lower extremities, and thrombus break away and travel to pulmonary arteries. So lower extremities thrombosis is going to lodge a thrombus in the pulmonary artery, and the embolism is treated with hyperbaric oxygen. This is a pulmonary embolism that is caused by the venous thrombosis. Whereas the arterial emboli is usually arise from the mural thrombus that adhere to one heart chamber or major artery. So if you need to know about the arterial emboli, arterial embolus usually arise from the mural thrombus, that is from the one heart chamber or major artery. Example is the branches of the carotid artery, most frequently the middle cerebral artery, and that led to the cerebral infarction. So there is a thrombus in the artery, that is a middle cerebral artery, is a branch of the carotid artery, then it leads to the cerebral infarction. The fat emboli, they are the particles of the bone marrow and other fatty tissue as well as severe fractures. So if there is a shortness of breath after the fracture, then the answer is going to be fat embolism. Next is the air embolism. The air embolism is due to air entering into circulation as seen in penetrating chest injury or criminal abortion, and that is also seen in deep sea diver. It is decompression sickness who return to the surface too rapidly. So there are three conditions in which air embolism is seen. That is seen in the deep sea divers, that is seen in the chest injury, and in the criminal abortion, air embolism is seen. Moreover, the last type of embolism is the amniotic fluid embolism. The amniotic fluid embolism is these emboli are caused by the escape of amniotic fluid into the maternal circulation. They can activate the coagulation process, and that can lead to DIC. And so if there is a pregnant lady during labor and postpartum, then you are going to take amniotic fluid embolism whenever during labor and postpartum, and or there is a pregnant lady. Shortness of breath on lying down is the characteristic of the retrosternal goiter. It's not the characteristic of any kind of embolism. There is one tricky MCQ, that is the point 108 of the Ruffy point. If there is both situations are given, for instance, a pregnant lady that encountered a fracture of the femur, so the answer could be a fat embolism or it could be an amniotic fluid embolism. So the point is that in this scenario, there is always going to be the mentioning of the time. So if the amniotic fluid, if the time is about 3 days, that is 12 to 72 hours, then the answer is going to be the fat embolism, whereas the amniotic fluid embolism, it occurs suddenly. So the rule is to be applied only when both the fracture and the labor is given in the scenario at the same time. Point number 109, the most common cause of pulmonary embolism is immobilization. The most common cause of pulmonary embolism is immobilization. The most common cause of venous thrombosis is prolonged immobilization, as venous thrombosis causes a pulmonary embolism. The most common acquired thrombotic disorder is the antiphospholipid syndrome, and the most common inherited thrombotic disorder is the factor V Leiden, and the most devastating effect of the oral contraceptive is thromboembolism. Now let's talk about Ruffy point 111. The most common cause of venous thrombosis is prolonged embolization. Pulmonary embolism occur mostly by DVT. The most common site of thrombi of pulmonary embolism is the femoral vein. This is important. The most common site of thromboembolism. So if the question says thromboembolism, then the answer is going to be popliteal. But if the most common site of thrombi of pulmonary embolism, then there is going to be femoral vein. In DVT, the emboli first get lodged into which of the following? It lodged into the pulmonary artery. In DVT, the emboli first get lodged into the pulmonary artery. A man presented with headache, fruncle on tip of the nose, he has high fever with redness and swelling of eye and increased intracranial pressure. The diagnosis is going to be cavernous sinus thrombosis. A 50-year-old man who has previous history of diabetic retinopathy and MI presented with chest pain. Coronary occlusion occur commonly due to thrombosis. He has a history of diabetic retinopathy and MI, and coronary occlusion occurs due to the thrombosis. Regarding superficial venous thrombosis, superficial, which is true, mostly in saphenous venous system. The superficial venous thrombosis occur in the saphenous venous system. Which findings are suggestive of bad prognosis in acute renal transplant rejection? Vasculitis and the thrombosis are the poor prognostic factor in renal transplant. What is the most important factor in pathogenesis of thrombosis? So endothelial injury is the most important factor. The most common cause of ischemia or the infarction in an organ is thrombosis. What is the most important factor in pathogenesis of the thrombosis? That we have already discussed, that is the endothelial injury. The most important factor for coagulation to begin is the rough endothelial surface. DVT, the emboli first get lodged into which of the following? The answer is the pulmonary artery, as we have previously discussed. Which of the following is most likely to be genetic cause of thromboembolism? The genetic cause. The most common genetic cause is factor V Leiden deficiency. Which of the following is most likely to be the genetic cause of thromboembolism? The homocystinuria. Talk about poisoning that is related to pulmonary system. So there are two important agents that causes the poisoning. One is the cyanide agent and the other one is the carbon monoxide. They both inhibit aerobic metabolism via inhibition of the complex 4, that is the cytochrome C oxidase, and therefore they are going to cause hypoxia, does not fully correct with supplemental oxygen, and anaerobic metabolism is going to increase, and both are going to lead to pink or cherry red skin, or usually post-mortem finding is going to be pink or cherry red skin, and also going to cause seizures and coma. So both are going to inhibit the aerobic metabolism and increase the anaerobic metabolism. And the cyanide is basically a byproduct of synthetic product combustion, ingestion of cyanogenic glucoside found in apricot or cyanides, whereas carbon monoxide is the odorless gas from fires, car exhaust, or gas heaters. The silent symptoms of cyanide poisoning is that it is going to have the bitter almond odor, and there is going to be cardiovascular collapse. Whereas in carbon monoxide poisoning, there is going to be a headache, dizziness. Multiple individuals may be involved. For example, family with similar symptoms in winters, classically associated with bilateral globus pallidus lesion on MRI, although rarely seen with cyanide toxicity as well. They are associated with bilateral globus pallidus lesion on MRI. The treatment of carbon monoxide is simple, that is hyperbaric oxygen or 100% oxygen, whereas the treatment of cyanide poisoning is hydroxycobalamin that binds cyanide and forms cyanocobalamin, and that is released in the renal system. And nitrites are going to oxidize hemoglobin into methemoglobin, and that is going to bind cyanide and that forms the cyanomethemoglobin, which is less toxic. And there is sodium thiosulfate that is going to increase the conversion of cyanide to thiocyanide, and that is also secreted renally. So hydroxycobalamin, nitrites, and the sodium thiosulfate are the antidotes for cyanide poisoning. Oxygen hemoglobin dissociation curve is going to be normal in cyanide poisoning. Oxygen saturation may appear normal initially, whereas in carbon monoxide poisoning, there is going to be left shift in the curve. There is going to be increased affinity for oxygen, and there is going to be decreased unloading of oxygen in the tissues. It binds competitively to hemoglobin with 200 greater affinity than oxygen to form carboxyhemoglobin, and is going to decrease the oxygen saturation of the hemoglobin. Let's talk about pleural effusion now. So there are two types of pleural effusion. One is a transudative effusion and the another one is the exudative effusion. So in transudative effusion, the protein content is less, whereas in exudative effusion, the protein content is more. There are mnemonics to remember the causes. So mnemonic to remember the causes of the transudative effusion is: some persistent people can cause nausea, that is SVC syndrome, that is a superior vena cava syndrome is going to cause transudative effusion. And the another one is the persistent is for peritoneal dialysis, P is for pulmonary embolism, C is for congested heart failure in more than 90% of the cases, another C is for cirrhosis, and N is for nephrotic syndrome. So some persistent people can cause nausea. Then exudative effusion, the mnemonic for the exudative effusion is picture map. Picture map is parapneumatic effusion that is associated with bacterial pneumonia and lung abscess. A picture map, that is the P is for parapneumatic effusion that is associated with bacterial pneumonia and lung abscess. And then there is infection, that is bacterial, viral, and fungal. Parapneumatic effusion is for P, that is associated with bacterial pneumonia and lung abscess. I is for infections, that is viral, bacterial, and fungal. And then we have C. C is for cancer, T is for trauma or tumor, chylomothorax. U is for uremia, R is for rickettsial infection, esophageal perforation, M is Me syndrome, that is ascites, hydrothorax, and associated with ovarian tumors. A is for asbestos, P is for pancreatic disease, then elevated pleural fluid amylase as well. So picture map is a mnemonic for the transudative effusion. Now let's talk about polycythemia, that is the Ruffy point 120. So there are three types of polycythemia. Polycythemia that is the rubra vera, polycythemia rubra vera, that is basically the primary polycythemia that is associated with decreased level of erythropoietin. Polycythemia rubra vera is the only type of polycythemia with decreased erythropoietin, and it is going to be increased plasma volume. So, and the bone marrow is going to be hypercellular. Moreover, the secondary polycythemia is caused by the other disorders. For example, the hypoxia that is caused by cardiac disease, pulmonary disease, or high altitude, carboxyhemoglobin, smoking, that is kidney lesions, erythropoietin secreting tumors, and abnormal hemoglobins are rare causes. Diuretic use. So the important cause is hypoxia that can lead to the secondary polycythemia. The important thing about secondary polycythemia is that the erythropoietin is always raised in secondary polycythemia, whereas it's always low in the polycythemia rubra vera, there is a primary polycythemia. The other thing is relative or apparent polycythemia, that is Gay-Box syndrome. That is a stress-induced polycythemia that occurs in burns or dehydration. The red cell volume is normal, but as a result of decreased plasma volume, there is relative polycythemia. Relative or the apparent polycythemia is more common than polycythemia rubra vera, and it occurs in middle-aged men, particularly in the smokers who are obese and hypertensive.